need new therapies for follicular lymphoma, and I think you know the answer to that. But we wanted to look at what we have and sort of see what the players are, and then talk about what's missing. So when we look at here's some data from a large series from a single institution looking at, this is from 1,300 patients from Stanford, and they looked at the treatment over 4 different eras. They looked looking from the bottom up in era number 1, the pre-anthracycline era, anthracycline era starting in 1975, the era of what they call aggressive chemotherapy and purine analogs in 87, and then the rituximab era starting in 1997. And you can see that in the first 2 eras, there was no change in the median overall survival. It was what we had learned before, 10 to 12 years. And in era 3, perhaps when we saw patients getting better supportive care and new agents, it increased. And in era 4, with rituximab, you see the median hasn't been reached yet, has been estimated to be over 18 years. But what's important here is that we do need new treatments because despite all these advances, there's been no suggestion of a plateau in any of these. So we see in follicular lymphoma, we believe that so far what we've seen in these only just about 15 years now is sort of this unrelenting, slow progression of disease. We may have changed the slope of these curves, but we probably haven't changed the amount of patients that are cured. So this is why we certainly do need new therapies. What we'd like to see is this kind of plateau that we see in aggressive lymphomas, which in most indolent lymphomas, we have yet to really prove this. With the introduction of rituximab, we're all familiar how this did, for the first time, increase the overall survival of patients with follicular lymphoma. And there are numerous studies. Anytime you added this on, you saw increases in progression-free survival, and long-term follow-up of such studies showed improvements in overall survival. So we know that follicular lymphoma had its overall survival has been markedly improved by the introduction of rituximab. That's not in doubt. So how can we make that better? And a lot of the studies have come from trying to understand the major mechanisms of action for lymphomas, and I'm going to try to balance between left and right and point to some things. So it's believed that the major mechanism of action for rituximab is down here, antibody-dependent cellular cytotoxicity, whereby natural killer cells and other Fc receptor-bearing cells lyse the tumor cells after engagement of CD20 and through the Fc receptor. Activate the NK, mostly NK cells carry this out, also monocytes and perhaps some other cells. But there is a contribution of a little bit of complement-dependent cytotoxicity, some direct pro-apoptotic effects, or perhaps this direct binding synergizes with chemotherapy. We know that. This, as an immunologist, I would love to see this happening, but this is probably a very inefficient thing that is cross-priming through dendritic cell antigen-presenting cells to activate a T-cell response. This probably does not happen unless you tweak this system with a number of different agents. So great efforts and billions of dollars, I think it's safe to say, went into trying to improve anti-CD20 antibody therapy. And based on understanding those mechanisms, trying to say boost each of those mechanisms. How do we boost ADCC, boost direct cell killing, programmed cell death? How do we boost complement-dependent cytotoxicity? And what came from these studies is rituximab has sort of been viewed as the standard. It's called a so-called type 1 antibody that has these effects, weak programmed cell death activity. But there was another antibody, the parent antibody that's used in Bexar, the mouse antibody, has a little bit of a different activity on the cells and has more programmed cell death. I heard this morning that Bexar may be resurrected, and I'm not sure if that's true. And then there was another antibody, ofatumumab, which is also type 1, and it has more complement-dependent cytotoxicity. And it also binds to a different CD20. But it was not, neither of these have been really shown, this antibody was really not shown to be better in follicular lymphoma. So along comes obinutuzumab. Now the technology to re-engineer antibodies, and what they were trying to, it's been around for a long time, what they were trying to do is by varying the glycosylation pattern, they were trying to boost ADCC, which they accomplished. They had to sacrifice a little bit of the complement-dependent cytotoxicity to do this, but they achieved what you see with the Bexar I should say, not Bexar, but the tosatumumab antibody, is a higher level of programmed cell death. And to be perfectly honest, I think this has been around a long time, this technology, and there may not be a coincidence that this antibody was not introduced by Roche until last year in most common lymphomas, non-Hodgkin lymphomas, which coincided perfectly with the expiration of the patent in the U.S. on rituximab and the rise of potentially biosimilars. So what do we know about, did we really make the antibody better? So let's look at some of the data in different lymphomas. And this is the first study that was done head-to-head with rituximab and obinutuzumab. And this is a relapse refractory rituximab-sensitive disease. And remember, we participated in this study, and I remember we saw that the response rate was higher with the obinutuzumab. And then this data was shown, I think, at an ASH meeting, I think in 2013. And there were audible gasps from the audience when this slide was shown, because there was so much disappointment that as a single agent, as a sort of a pure immunotherapy, there was no advantage to this in follicular and indolent lymphoma. And I think this is a great disappointment to people. And this is the data that we have that looks at it as single agent in follicular lymphoma. And so that's a big disappointment, because years and many, many companies spent time trying to optimize these antibodies. And this really is a pretty minor effect. However, this is the study that was presented by Dr. Marcus at the plenary session of ASH this last year, and it was looking at combining traditional chemotherapy, sort of investigator's choice in the front line for follicular with obinutuzumab chemo or rituximab chemo. And then they added maintenance doses, which possibly complicated things further. And there was indeed a statistically significant advantage to obinutuzumab in progression-free survival, but I think this is a modest advantage. And I think that we have to ask ourselves that if we need to use rituximab for some other reason, I think rituximab is still fine. And it's clear that if you're using a single agent, for instance, if a patient's intolerant of rituximab for some reason and you want to use obinutuzumab, you shouldn't feel like you're sacrificing, because in a randomized study for relapse disease, they were exactly the same. Don't get me started on maintenance. I'm not a big fan of maintenance therapy, and I think it was Dr. Pagel mentioned this before. And we don't have any, I'll just go through this quickly. We do not have any evidence that maintenance therapy prolongs overall survival. You get the same benefit whether you sort of like you can pay me now or you can pay me later. If you just use the rituximab at the time of relapse, it seems to be the same. And I personally favor, and I think many of my colleagues in academia, we favor putting patients on trials rather than giving them a maintenance therapy that has no curative potential. And so I think we do maintenance less, but I know in the community maintenance rituximab is used a lot. And I think it's also been heavily lobbied for. All apologies to the Genentech Roche people here, our supporters today. But I think it's been heavily touted by them. And the truth is we really do not have proof that it improves overall survival. And that's the question. Do we need new therapies? Yes, we need new therapies. Maintenance therapy is not improving overall survival, which is what we really need. Once again, and here is the larger study that's often touted that really tried to get people to use maintenance rituximab, the PRIMA study. And of course, if you're giving continuous therapy, you're going to have improved progression-free survival, but there's no improvement in overall survival. And so unless that changes after a much, much longer follow-up, I don't think that there's too much value to using maintenance. The time I would use maintenance is occasionally we have a patient who you really think is very distraught, and if they choose this themselves, but I let it be driven more by the discussion with the patient, and I don't generally favor using scheduled maintenance. Okay, so what else do we have now? We have bendamustine. This is the data in rituximab refractory patients. We know bendamustine's one of our if there is such a thing as a favorite chemo for follicular lymphoma, I don't think there is, but it's a very active drug. And we know that when we look at newly diagnosed indolent, which includes follicular or mantle cell lymphomas, and we compare it to R-CHOP, we see that it looks like we get it, at least this non-inferiority trial looks like it's at least as good and probably better. BR is probably better than R-CHOP. So we know that anthracyclines are not really necessary to improve survival in follicular lymphoma. So this is really some of the data that helped to establish bendamustine as our best chemotherapeutic option. This is breaking down this study by the different subtypes. And clearly, we do not need to use CHOP because the anthracycline is obviously not providing with anything except a lot of side effects. We'll come back to another reason why not to use that later. So bendamustine is good stuff. We heard a lot about venetoclax. This is one of the studies on venetoclax that I think is a sort of a pure, just looking at purely what it can do by itself. And we know that since it targets the BCL2, the oncogene that's overexpressed in follicular lymphoma due to the translocation, it does have activity, and it's very important, and Dr. DeVos can tell you a lot more about this agent in these studies. But certainly a third of the patients respond, and it's a very active agent, and I think a key is what we're learning now in larger randomized studies is how to integrate venetoclax and BCL2 inhibitors into current chemotherapies and maybe non-chemotherapies. That's something that's just now being explored. So this is an active agent. So coming to some things about immunotherapy in follicular lymphoma, and I'll talk more about immunotherapy for aggressive lymphomas in a later talk, but I wanted to remind you of some interesting points about follicular lymphoma. And that is that follicular lymphoma has the highest spontaneous remission rate of any human cancer. So about up to a quarter of patients can have this waxing and waning over time, and this is thought to be immune mediated. It's responded to things like we used to treat with vaccines, and we saw some very convincing responses when we were doing those very specialized single institution studies. And when you look at gene expression profiling, there are actually immune signatures that suggest that there's an ongoing dialogue between the tumor and the immune system. In fact, the favorable gene expression signature involves T cell activation, and unfavorable one involves macrophages. And there's this very interesting study showing that in follicular lymphoma, within the follicles, you have these activated CD8 positive cytotoxic T lymphocytes, and the degree and presence of these correlates with improvement in overall survival. So this disease is primed to respond to immunotherapy. So all we probably have to do is somehow try to unlock this. And if we give chemotherapy, we're probably killing off a lot of these cells. So we really should be trying to think about ways to be using these agents we've been talking about to sort of promote this response. Or what I tell patients, at least give them the chance to utilize this endogenous response against the tumor. And something else that we noticed in follicular lymphomas is that there is expression of the PD-L1 inhibitory ligand that blocks binds to the brake on T cells that are infiltrating the tumor. So we really ought to be trying to favor this kind of response here. Lenalidomide we've talked a lot about, and you can see there's lots of different mechanisms how it favors this, and that may be why it has such good activity. And here's the phase 2 study from MD Anderson looking at rituximab and lenalidomide, once again sparing any chemotherapy. This regimen should not disrupt any of these ongoing immune reactions that are present within the tumor microenvironment, and indeed they got an excellent 98% overall response rate in follicular lymphoma, 87% CR, which is almost hard to believe. And this led to the relevant study, which is a randomized comparison of lenalidomide plus rituximab versus R chemo. And I think it'll take a couple more years. Herbert Eradat can tell us perhaps when this is going to be released, but it's probably several years away because, of course, follicular lymphoma has a very long natural history, so we need a longer follow-up to determine this. We've already talked about the BTK inhibitors and the BCR inhibitors, which are very active. And I wanted to make a plug, given the immunologic data I just showed you, that despite sort of idelalisib, the PI3 kinase delta being given a bad name, it still has an excellent response rate. And some of its other activities are actually potentially very important. It turns out that PI3 kinase delta is present in several immune suppressive cell populations within tumors, within these myeloid suppressor cells and within regulatory T cells. And if you give a PI3 kinase delta inhibitor, you turn these things off. And this is probably why we see these sort of autoimmune type side effects with PI3 kinase delta inhibitors. So I think that this is very interesting, and also you can see in mouse tumor models, you actually can see prolongations of survival. You can see suppression of tumor growth when you give a PI3 kinase delta inhibitor in a tumor-bearing host. So really we should be thinking about not as things like PI3 kinase delta inhibitors in follicular lymphoma as so much cytotoxic agents, but we ought to be thinking of these as building blocks to potentially build new immunotherapies. Histologic transformation in follicular lymphoma, Dr. Erdath's going to talk about Richter's transformation, but this is still one of the most feared complications, right? A risk that varies between different studies of 5 to 31%. And there seems, interestingly, to be sort of a plateau that if you don't transform after 15 to 16 years, maybe your disease is genetically programmed not to transform. Now, it used to be said, I remember when I started my training, that advanced follicular lymphoma that then transformed had about a 1-year overall survival. And indeed, in the rituximab era, since patients are less heavily pretreated, we don't think that that's the case anymore. In fact, we're seeing a much better survival, 5-year overall survival in over 50% in many cases. And Herbert can contrast that to Richter's transformation of CLL, and that's really tends to be still a nastier situation. Now, something very interesting and important in terms of choosing initial therapy, and that is that patients who are anthracycline naive have a better outcome than patients previously treated with anthracyclines. So this may be one reason why not to give, another reason yet, to not give R-CHOP when you're treating follicular lymphoma patients up front. Save the anthracycline for the time just in case you have transformation. And the outcome, there's one study that shows that the outcome of R-CHOP naive patients who transform and then get R-CHOP can be comparable to those who have de novo DLBCL treated with R-CHOP. So this is very important in terms of choosing initial therapy. CAR T cells we'll talk about a little bit later, but you can see CAR T cells can be very active, at least in this single patient from the NCI treated with CAR T cells targeting CD19 and very refractory follicular lymphoma achieving long remission. So this is the way that I think about our current status of follicular lymphoma therapies. I tell patients that what we have is we have cards. We have a set of cards. And what we do is we try to decide when to play each card. And it seems like we're being dealt more cards all the time. In fact, my list got longer just in the last couple of days of adding more cards. So that's the good news. So the issue is not what we have, but I think how you play it. When are we going to play each card? And you can see that depending on the severity of your disease, you've got all these. And this is obviously a partial list. We have many more of these. It's also important to know that for follicular lymphoma, since we still don't have a cure, even in the NCCN guidelines, it says, given the incurability with conventional therapy, consider investigational therapy as the first-line treatment. So this is why follicular patients, it may be good to talk to your academic colleagues and find out what trials they have, because we still don't know what the best thing to do is. And this obviously offers your patients the chance to get novel agents. So you can say that here may be sort of an algorithm for using these new agents we have, watch and wait. We don't do this very much anymore because we know that we've got rituximab alone. We can do that if they don't require an immediate response. Good old-fashioned chemotherapy, bendamustine, or maybe we'll be using lenalidomide or BCR kinase inhibitors with rituximab. Clinical trials, new investigational agents, we'll look forward to seeing the BCL2 inhibitors, anti-PD-1 maybe, we'll talk about that. And only then using things that are very drastic like myeloablative, non-myeloablative stem cell transplantation and maybe CAR T cells. So since we're in Southern California, we want to get it wrapped up on time. And here's just my conclusions. We've gotten incremental benefits in overall survival and quality of life, but no clear curability. The average overall survival has improved to 15 to 18 plus years and counting, and simply most patients may be able to simply outlive their follicular lymphoma. Now we've got our current therapeutics, it's interestingly now address distinct tumor characteristics and mechanisms of action. So now we can really rationally begin to combine things. Proliferation, we can affect with chemotherapy, apoptosis resistance and cell survival using these various small molecule inhibitors. We engage innate immune effectors such as NK cells with anti-CD20 antibodies. And we want to bring adaptive T cell immunity in here with checkpoint inhibitors, CAR T cells. So optimizing these combinations, even with what we have right now without new drugs, is going to take years. And then histologic transformation remains a challenge, but perhaps we have an answer to that. So I'll close with one other thing. This is sort of our old therapy. We had chemotherapy and anti-CD20 antibodies. Now we seem to have this much sort of juicier situation where we have chemotherapy, anti-CD20 antibodies, got a big fatter burger here because I think our antibodies are a little better. We've got BCR inhibitors, BCL2 inhibitor, checkpoint inhibitors. It's getting kind of confusing, but we're still looking for the secret sauce, right? We want to know, what is the secret sauce? Is it a combination of these, or is it something else new? And so it'll be exciting in the next few years to wait for that. That's it.